So muscle relaxants are neuromuscular blockers. So these are the things that I'm going to talk about very briefly. So we'll classify muscle relaxants. We'll talk about the mechanism of action, molecular structure, pharmacokinetic and pharmacodynamic properties. Talk a bit about reversal, and we'll talk about some of the properties that make for an ideal muscle relaxant. So the general principle, muscle relaxants are used to achieve optimal conditions for intubation by relaxing the intrinsic laryngeal muscles, and also achieve optimal conditions for surgery as well, like your abdominal surgeries where you need muscle relaxation. We know that at least 80% of the nicotinic acetylcholine receptors must be bound in order for there to be a clinical paralytic effect. And they're categorized according to their mechanism of action, depolarizing, non-depolarizing, and then they're sort of further classified by molecular structures, you'll see. So your depolarizing drugs, fortunately enough, the only one in clinical practice is SUXAMETHONIUM, which makes it easier for us. We only have to learn one. And these act as agonists at the acetylcholine receptor. The non-depolarizing drugs, they act as antagonists, and they have no intrinsic activity. So with SUX, you'll see they will it will actually depolarize or activate, causing the initial fasciculations followed by the flaccid paralysis, whereas you won't get that with the non-depolarizing because it has no intrinsic activity. And then the non-depolarizing are further characterized into AMINOSTEROIDs and BENZYLISOQUINOLINUMS, which I'll talk about later. So starting with SUX or succinylcholine, it's effectively like two acetylcholine molecules joined together. As I mentioned, it's an agonist at the acetylcholine receptor, causing a fasciculation, then followed by a flaccid paralysis. It's water soluble, but not lipid soluble. So most of, I think all the muscle and neuromuscular blockers are lipid soluble, are lipid insoluble. And the significance of that being that they don't cross the placenta, they don't cross the blood-brain barrier, and interestingly, if you ingested a vial of SUX, it shouldn't have any clinical effect at all. 90% of the laryngeal muscles are paralyzed within 50 seconds, so it's quite quick acting, and therefore it's ideal for RSIs. It starts to offset at about 3 minutes and is usually completely washed out within 15 minutes. It's metabolized by plasma cholinesterases, so not your acetylcholinesterase that are in the neuromuscular junction, but that are actually in the plasma. And these are made by the liver. And you'd need to be mindful, therefore, with people with chronic liver conditions that they may have, this may potentiate the block. There are many side effects with SUX. It's quite a dirty drug, namely hyperkalemia. I mentioned earlier on about denervation injuries and how upregulation of those extrajunctional receptors can cause quite a significant hyperkalemia. And usually for your average intubating dose of SUX, you'll get a rise in your potassium levels of 0.5 millimole per litre. You can get quite nasty myalgias because of the depolarizing effect and the fasciculations, and particularly this is the case for young women undergoing day surgery. Interestingly, well, apparently it can be sort of prevented by giving a bit of rock beforehand, giving a non-depolarizing agent at 0.1 mg per kg about a minute before you give propofol. I think as well lidocaine works quite well. Can also cause bradycardia, typically in repeated doses or in pediatrics, because of its its nature of causing fasciculations. It can increase your intracranial pressure, your intraocular pressure, your intragastric pressure. So you shouldn't really be. You should try and avoid it in head injury patients, avoid it in penetrating eye injuries, And then in terms of as far as the intragastric pressure is concerned, you may consider cricoid if you believe it. It works. And then the other thing to mention is anaphylaxis. It's the number one paralytic drug for causing anaphylactic reactions. Just a bit about some conditions related to SUXAMETHONIUM. So one is SUXAPNEA, and this is a result of a deficiency in plasma cholinesterase. It's autosomal recessive, so you need two of the bad alleles in order for it to have any significant effect. And there's several different genes implicated. And what you notice in these patients is that they'll just fail to spontaneously breathe. The next clue that you'll get is a train of 4 will show a phase 2 block, which I've shown on the right. The first sort of 4 stimulations are normal, and then the little red triangle indicates where SUX has been given. You should normally see a phase 1 block with SUX, where the amplitude is reduced, but the four stimulations are all of the same height or same amplitude, and that's because SUX is a depolarizing agent and it blocks the acetylcholine receptors. And then a phase 2 block is more typical of your competitive inhibitors, like your non-depolarizing agents, where you'll see some fade. But in this case, with SUXAPNEA, and you have a deficiency of the cholinesterase, a deficiency of plasma cholinesterase, you'll interestingly get a phase 2 block. So your clues for SUXAPNEA is a patient who's failing to spontaneously breathe, and when you do a train of 4, you see a phase 2 block. Notably, you can get a phase 2 block if you give subsequent doses of SUX. And I think that's more to do with the feedback at the presynaptic cleft. Treatment for SUXAPNEA is supportive, so you effectively just wake them up on ITU when they're ready. You just wait for them to spontaneously breathe. And in the case where it's suspected, the patient and the family should be screened, and there's many different genes involved, as shown there. The next thing is malignant hyperthermia, which is classically associated with SUX, but also your volatiles as well. It's an autosomal dominant condition in comparison. It's got many genes involved, some of which are associated with the ryanodine receptor. And as we discussed earlier, that sort of regulates calcium release. And what happens is you get excessive calcium release, which causes muscle contraction and rigidity, leading to hyperthermia. And then you get muscle breakdown, which can result in acidosis and AKI. The treatment for this is dantrolene at 1 mg per kg, and you can repeat the dose as necessary. And this just seems to inhibit the contraction, the excitation-contraction coupling. Treatment should also involve some conservative measures like active cooling, and you should remove the trigger. So including if you've got sevoflurane in your circuit, you should try and wash that out, and even to the extent of changing your anesthetic machine. So now on to non-depolarizing agents. So the first ones we'll talk about are AMINOSTEROIDS, and I mentioned how these work. They're competitive antagonists and they have no intrinsic activity. AMINOSTEROIDs include your rocuronium, pancuronium, and vecuronium. They have this androstened skeleton where they kind of look like androgens with this like steroid nucleus. They've got a nitrogen-containing group at both ends. It can be a tertiary amine group or quaternary amine. The tertiary amine has 3 hydrogen bonds and is therefore negatively charged, where the quaternary amine has 4 hydrogen bonds and is therefore positively charged. The importance of this is it affects its metabolism. So the negatively charged amines are more secretable in your bile and undergo liver excretion. If both end groups are charged, it's a bisquaternary molecule, and if one nitrogen group is charged, then it's monoquaternary. These drugs are generally excreted in the liver and the kidneys, and they are affected by things like your cytochrome P450 enzymes. So your carbamazepines and your cimetidine, for example. So the monoquaternary aminosteroids, this includes rocuronium and vecuronium, and these guys are slightly negatively charged. Rocuronium, the intubating dose is 0.6 mg per kg or 1.2 mg per kg for an RSI. It has quite rapid onset, and that's related to its low potency. Because it's relatively quite low potent, you have to give more of the drug, and that has a big effect on onset, because the more molecules of rock that are floating around in your neuromuscular junction, the quicker it's going to be, because it can bind to those receptors and do its job. The onset for your standard dose is about 75 seconds, and it lasts about 30 minutes. It's excreted mainly in bile and some of the urine, and I spoke about why that's the case. It's because of its sort of negative charge, because it's only got this three. It's monoquaternary, so you've got one nitrogen that's got 3 hydrogens, and the other nitrogen has got 4. It has an active metabolite, which is very weak potency, which is your 17-deacetyl rocuronium. It has mild vagolytic effects in large doses, so you can get a bit of a tachycardia with it. And of the non-depolarizing drugs, it's the highest risk of anaphylaxis. Vecuronium is a powder that needs to be reconstituted. It's much higher potency than rock, with its intubating dose at 0.1 mg per kg. And the result of this being, it actually, despite it being much more potent, its onset is much later, so at 180 seconds, for the reasons that I explained. Lasts about 30 minutes, again, excreted in bile, some of the urine, has an active metabolite, 3-hydroxyvecuronium, which is 80% as potent as the actual drug vecuronium itself. It has no direct cardiac effects, so if you do have an atopic patient, it's really the drug of choice, and you rarely get histamine release with it. Pancuronium is a bisquaternary aminosteroid. Its intubating dose is at 0.08 mg per kg. Onset of about 220 seconds, lasts about 75 minutes. Can have vagolytic effects and sympathomimetic effects, and does not cause histamine release. Pancuronium is the drug of choice for A to B. Sorry, ignore what I said in the last slide. So here's just a summary of your aminosteroids. Of note, again, just the ED95 is the dose at which there is blunting of 95% to your first amplitude in the train of 4. Your intubating dose is generally double your ED95. The onset is from time of injection to 95% of 95% blunting of your first train of 4, and then the duration is from injection to recovery of about 75% of your train of 4. Of note, rapicuronium, pipicuronium and rapicuronium aren't in clinical practice, and the rapicuronium, if you look at its properties, seems like a great drug and is very similar to Sux, really, in duration and quick onset, but we don't use it because of there's been lots of cases of bronchospasm and it's been withdrawn. Right, so the next group then are your BENZYLISOQUINOLIUMS, and this is atracurium, cisatracurium, and livicurium. General principles for these drugs: they're very slow onset. They have a good side effect profile. They have 2 quaternary ammonium groups, as shown. They're joined by a chain of methyl groups, and they've got these 2 chiral atoms, which are circled there in the diagram, and they're at either end. That's your nitrogen and your first carbon, and this allows for loads of stereoisomers, which are effectively just different sort of shapes of the drug. So they have the same molecular structure and the same sequence of chemical bonds. It's just when they are arranged in three-dimensional space, they look different. Atracurium has about 10 different stereoisomers, one of them including cis-atracurium, and your average vial of atracurium has about 15% cis-atracurium in it. The intubating dose is 0.5 mg per kg with an onset of 110 seconds, lasting about 40 minutes. What's unique about this drug is it undergoes Hofmann elimination, which is a temperature and pH dependent. 45% of the drug goes through this pathway, 10% passes into the urine, and the rest of it undergoes ester hydrolysis. And while there's no active metabolites, it does produce this, the ester hydrolysis and the Hofmann elimination produces this chemical known as lodanosine. And interestingly, it's associated with seizures in animals, but has not been shown to be the case in humans. It can cause a small bit of histamine release on injection, and that can be mitigated by using lower doses and slowing the infusion rate. Cis-atracurium, as I mentioned, is an isomer of atracurium. The intubating dose of 0.1 mg per kg, onset of 150 seconds, lasts about 40 minutes. 77% of this undergoes Hofmann elimination, so much more than atracurium, and also undergoes ester hydrolysis. But we actually see less lodanosine production than atracurium, and the reason for this is because cis-atracurium is much more potent, you're giving less of the drug, so therefore you're making less lodanosine, even though far more of it undergoes Hofmann and elimination and ester hydrolysis. Cis-atracurium along with atracurium can be used on ITU as an infusion. This is because it doesn't matter if your kidneys or your liver are knackered, so it can be quite good in multi-organ failure. Mivacurium is your last of this lot. They do have some structural differences, including its ester groups are flipped, and it has got these 3 methylene groups on either side. It has 3 different isomers, with trans being the most common in the mixture. It does not, because of these differences molecularly, it doesn't undergo Hofmann degradation, and instead is actually metabolized by your plasma cholinesterase, much like your SUXAMETHONIUM. And therefore, in deficiencies, this can lead to a mivacurium apnea, similar to a SUXAMETHONIUM apnea. The intubating dose is 0.15 to 0.2 mg per kg with an onset of 170 seconds, and it lasts 16 minutes. So here's just a summary of the BENZYLISOQUINOLINUMS, and you can see that atracurium is one of the more least potent ones, but actually has the faster onset, but not really used for our size because it's a bit too long of an apneic period. And mivacurium, because of its plasma cholinesterase, has a very similar duration to SUXAMETHONIUM. Reversal of muscle relaxants. So this is important because if you fail to reverse these patients after surgery, they're at risk of hypoxia, decreased ventilation, and dysfunction of their vocal cords, which can lead to aspiration. So you should really fully assess the neuromuscular function and appropriately reverse. And you can do this in 2 ways. You can do it clinically, or you can do it more objectively using a train of 4. And the clinical markers that we could potentially use but aren't actually very reliable are a head lift for 5 seconds, decent tidal volumes that are appropriate for their weight, tongue protrusion, grip strength. But the train of 4 is a much less subjective way of assessing for reversal. Your main drugs that we use are your acetylcholine esterase inhibitors, so neostigmine and sugammadex. So neostigmine is an acetylcholine esterase inhibitor. It's used for your non-depolarizing drugs. You can't use it for SUX. SUX is really short-acting anyway, but the neostigmine will actually inhibit your plasmacholinesterase, so it may actually just prolong the block if you used it in SUX. What this does is it increases your acetylcholine levels and the competition for the binding sites. It's generally given with an anticholinergic such as glycopyrrolate because it can have muscarinic side effects causing a tachycardia, increased salivation, bronchospasm, and increased intestinal motility. Sugammadex is used for aminosteroids and typically rock because it seems to bind strongest with rock, and there seems to be less dissociation with rock uranium. It's got this gamma cyclodextrin structure with these sort of 8 sugar molecules coming out of it. It's effectively just mops up rock uranium in the plasma, and this is freely filtered at the glomeruli. The last part is just to talk about the ideal muscle relaxant. So there is no perfect drug, and all the drugs that I've mentioned actually don't tick all these boxes. And generally what we tend to do is just use the drug that's appropriate for a very specific clinical situation. I don't know, like your 1.2 mg per kg for your ROC, for your RSIs, or, you know, atracurium if you've got bad kidneys and liver. But ideally we want a drug that's rapid in onset. So something that within less than 1 minute has all the intrinsic laryngeal muscles paralyzed. Something that's quite short acting, so starts to be metabolized within 5 to 10 minutes and is washed out after 15. Something that is quite safe and free of adverse effects. So you don't want any anaphylaxis, hyperkalemia, your malignant hyperthermias, your apneas or anything like that. And then you want something that's quite reliable. So something that's got a good shelf life, has a very consistent offset, regardless of your liver or kidney status, and something that doesn't accumulate if you're giving subsequent doses. And then just to wrap the last bit up then, I've got some more true-false questions if you guys want to speak up again. So contraindications to SUXAMETHONIUM include A, presence of renal failure, true, false?
Come on, everyone. Unmute yourselves.
False. Nice. 48 hours after major burns.
True.
True.
Malignant hyperthermia.
True.
True.
Pregnancy.
False. False.
Day-case surgery.
False.
False.
Great. Regarding atracurium, it has 4 chiral centers and 10 isomers.
True. True.
Undergoes Hoffman elimination.
True.
True.
Hoffman is potentiated by hypothermia and acidosis.
False.
False.
Yeah. A product of its metabolism is laudanosine.
True. True.
And laudanosine is associated with seizures in humans.
False.
False.
God, it's too easy. Sorry, guys. These are just some of the sources that I used for this. And thanks. If you have any questions and some feedback would be great, just so I can improve and get some pointers.